Hi everyone, welcome to the last OSCE session this week. Got a few familiar names and faces back again. Notice that some of you have contributed as well, sent us either an email or a messenger, Facebook message, and got some really good responses today. Hi Natalie. So really well done all of you that took part. Please feel free to drop me a message if you want to have a chat about anything. Hi Fiona. Fiona. You might have noticed on the Facebook group page, found a really good article about Gyan-Barre syndrome. So that was really good. I'd like to encourage that a bit more actually. So. Because we've had some really good justifications, but if you can have a look at the research literature as well, that would be brilliant. That'd be really good. So we're going to finish off this session today about the elbow. As always, it's never just about one thing. There's always loads of things going on. So hopefully you've seen some of the sessions before. I've put them online. So if this is the first time you're seeing this OSCE, then have a check of some of the other videos that kind of led us up to this point as well. So this is me. Most of you should know who I am now if you're here on this session. And just another little a little nudge as well. So if you want to join us on any classes, online classes that we're doing, so exercise classes, we've got Pilates and kettlebells, and there's some yoga sessions. There's all sorts going on. So if you want to have a look at our movement therapy clinics Facebook page, then the links are on there, and it's also on our website, which is mtclinics.com, so you can have a look at that as well. And just a little plug for next Monday. So we've got two things going on Monday. We've got my usual 6 o'clock OSCE session, and we'll do another new OSCE for you to have a think about over the week. And I'm also doing a session with Dan Lawrence. It'll be the third week this week, and it's not going to be just a tendon talk. So we had a question from someone in the group about clinical testing. So we're going to be focusing on that this coming Monday. Okay, so clinical testing this Monday rather than just tendons. So this is what we've done so far. We've looked at a case history, picked out some key points, and then we started to create a sieve and then justifying clinical impression. So we're going to go through some of the things that you guys have found some really good information. So we're in the third session now. So what do we do? What do we do with this person? So these are the key points from the sieve. So she was just a bit of a summary again for you, just to refresh your memory. She's a 41-year-old female. She was a secretary on and off since she left school. She drinks a lot of alcohol. She's a smoker, has self-proclaimed poor nutrition, and she's also a vegan. She's divorced, got 2 kids living at home who are both grown up. Stressed, tense, and changing mood all the time. So there's a lot of stuff going on with this person's life, which would impact her ability to adhere to any kind of rehabilitation program. And we'd have to, if she was safe to treat, then and we could help her, then we'd need to really think about her lifestyle. And how we might be able to help her with those other things that are going on in her life. The main complaints were, she didn't realize this, but she had a slight palsy or spasm on the left side of her face. She had upper extremity weakness and intermittent paresthesia into the arm and down the elbow. She'd had that for 6 months. She'd also had specific elbow pain for the last 2 months after a busy period at work, and she works at a PC, and she complained that it was painful work whilst using a screwdriver as well. She also complained of dizziness, vertigo, urinary urgency, and she'd had that for a year, and diplopia, which is double vision. Okay, so there were quite a few things, as usual, going on with this lady. So some of the things that you guys have put in the Facebook group, so you may have heard of these before, might not have done. I've got ulnar nerve entrapment, cubital tunnel syndrome, Parsonage-Turner syndrome, which is like a brachial neuritis. Worth having a look at that one. It's quite a rare condition, but that was really good. And then an epicondylitis, or epicondylopathy, as they tend to be called now. So basically like a tennis elbow. Tendinopathy, which is good. And a problem with the musculocutaneous nerve, and we asked for a nerve root as well, so C5, 6, 7. So maybe there was an issue with her neck that was referring down her arm. Okay, so that was really good. Some good thoughts there. These were the things that I gave you a little bit of a nudge towards. So we had something called a UMN lesion, which is an upper motor neuron lesion. So we're going to talk a little bit more about that in a sec. And that was because of changing gait, changes in mood, the palsy in the face, and the urinary urgency, and the paresthesia as well. So that could they could all be linked to some kind of upper motor neuron lesion. So we will go into that in a bit more detail if you've never heard of it. But what you would do is because of the palsy in a face, it might have been trigeminal neuralgia that was mentioned in the case. And you can do what's called a cranial nerve exam. I'm not going to go in too much depth about those because it is quite complicated, but that's something we can explore on future sessions. Yeah, so what the cranial nerves are, and how you would test them. So we can have a look at that. A full neuro exam, but then depending on what came out of the exam, and you'll see why in a sec when we move on to the next few slides, will depend on where you send them next, because it could be an A&E referral, or it might be to the GP. So it depends on how they present. Okay. We had some nerve issues in the arm. So it was a radial nerve distribution. Cool. No problem, Fiona. Yeah. It's a radial nerve distribution because it was over the elbow, and if it's on the lateral elbow, that bit there is supplied by the radial nerve. So that's all of the extensor group around that region, and so it's quite often overlooked actually for people who come in with tennis elbow issues. There may be some kind of neural component, and not necessarily a nerve root problem, so from the neck, but some kind of nerve tension around that region, which is causing an irritation of the nerve around that region. So there are some things called nerve tension tests that you can do as well, upper limb tension tests. So again, that's one for another session, I think. I think what we'll do is when we get to the end of all the OSCEs that I've got in the bank, then we can start doing some neurological testing, that kind of thing, and exploring those as well. Maybe that's something Dan and I will talk about on one of those sessions too. So if you did have a radial nerve issue, or there was arm weakness, paresthesia, you would need to do a neurological test. And so you would normally test reflexes, you would test power, their sensation, so the light touch, sharp touch, and vibration sense as well. So and there are reasons for testing each of those things, and again we'll go into more detail on those in future sessions. Musculoskeletal elbow, there were specific symptoms in the elbow after increased work, so it could just be tennis elbow, yeah, so a lateral epicondylopathy, and or the old epicondylitis. And you can do a couple of tests with that. There's a Cosen's test and a Maudsley's test. So I'll show you that one, because that one's easy enough to show you. And I don't know whether you remember, but the old grip strength machine. So we use those if anybody's got any elbow problems, wrist problems. We'll do a grip strength, so we've got objective data to see how the issue with their elbow or their forearm or their wrist is affecting their grip. Because sometimes the pain doesn't change very much. especially in the first few sessions, but their function improves. So, and unless you test it, you can't. The patient won't know, so it will just feel the same. So if their main focus is pain and you don't test function, you've got no baseline for their functional capacity. So it's well worth doing some kind of strength test or endurance test, if depending on the area of the body. And then we had an issue with nutrition. So she had a vegan diet, and we're going to explore that a little bit more in a second as well. I've spelt that wrong, but that should be a dietitian. And so it could either be a GP referral, depending on the networks in your area or your contacts that you have. We have a dietitian working with us, so I'd refer her to our dietitian for that. And quite rightly, Bonnie picked up on this one last session. If it's something, because we mentioned that if you have a vegan diet, you usually have a B12 deficiency, well, unless you supplement the diet. So it usually presents with neurological symptoms, but it's usually bilaterally because it's a systemic disorder rather than a biomechanical one. So if something is systemic in nature, it usually affects both sides of the body. Yeah, so like rheumatoid arthritis, it would be both sides of both limbs would usually be involved. But osteoarthritis is usually one side because it's more of a mechanical presentation. Okay, so that gives us a clue whether it might be more biomechanical or more systemic in nature. Cool. So I'd ask you to have a look at Guillain-Barré syndrome. Just move me out of the way so you can see the reference there. So I just picked this up from the NHS website. So if you want to have a look at the references there. So Guillain-Barré syndrome tends to start in your feet and your hands and then spreads to the arms and legs. And it affects the myelin sheath around the nerve. Okay, so the body it's like an autoimmune disease. So the body will start to attack its own nervous system. And you'll get numbness, pins and needles, muscle weakness, pain, and usually problems with balance and coordination. But usually these symptoms will affect both sides of the body because it is a systemic condition. Okay, but our person was more unilateral. Okay, so it was less likely to be this, but it could be on the list. And I know that some of you had never heard of it before, so it's useful to be aware of these things. Just move me out the way again. Okay, so the symptoms may continue to get worse over the next few days or weeks, depending on how long they've had it. Some people are only mildly affected, but some may have difficulty walking. Okay, inability to move the legs or the arms or the face. Okay, so that was one of the reasons why Guillain-Barré might be in there. Yeah, it's a strange one, Natalie. So it's one of those ones you either know it or you don't, and then when you do know it, you very rarely see anybody with it because it is quite a rare condition. But it's worth having there in the memory bank just in case to drag out one day. Higher risk with male, higher risk with males and young adults. The person that I've treated with it was a lady, and she was really ill. She had some other conditions as well, but there wasn't really much we could do. She had a lot of pain, so we were trying to manage her pain for her. There was nothing we could do about the condition. Because that was being managed at the hospital, but we were working on some kind of pain relief for her. So here's another reason why it was considered. Not difficulty breathing, but double vision. Okay, so there may be blurred or double vision. So again, have had one female, one male. Okay, cool. Thanks, Bonnie. Yeah. Problems swallowing or chewing. Yeah, I had the lady that I saw used to have something called, she had Guillain-Barré and she had myasthenia gravis as well. So myasthenia gravis is a problem with the acetylcholine. So when a nerve impulse comes down, when a nerve impulse comes down into the junction at the neuromuscular junction in the muscle, it releases something called acetylcholine, which is a neurotransmitter. So then as the nerve impulse comes down, it then gets changed from an electrical signal into a chemical one. And then that chemical then crosses across into the muscle, and that kickstarts then the contraction process of the muscle. And what happens with myasthenia gravis is that there's a buildup of acetylcholine. So the nerve impulse will come down, but then nothing will go across. So, and then the neurotransmitter then builds and builds and builds, and then all of a sudden it all goes across in one go. Yeah, good, John, brilliant. And what happens is you can't control movement. So this woman would she'd be standing in line at a supermarket with money in her hand, and then she would go to give the money over, but couldn't let go of it because her fingers wouldn't release, and she would have those kind of spasms. So we've had a couple of questions there. With hindsight, I've had one, but referred to GP anyway due to several issues. Yeah, good, perfect. That's exactly what you do. So with Gyan Barre, it's probably a GP referral, this one, unless you were concerned, unless you had all of the other factors. So with this particular case, I would have referred her to A&E. And the reasons for the referral to A&E were because of the palsy in the face, and the paralysis, and the double vision as well. Those things would have been enough of a red flag for me to say there is something going. I wouldn't have been able to diagnose it, because you can't diagnose these conditions in a clinic. They need further investigation. But I would know that there is something not right with her brain or a spinal cord. Yeah, that there is something going on there that I'm not happy with, and I'll show you an example in a second. Okay, so it will show you the kind of tests that I would do in clinic, the neurological exam, and what would happen then. Would they get all the symptoms? Yeah, Natalie's just asked, would they get all symptoms at the same time, or one's added bit by bit? It would depend. With the person that I had, she had a problem with the breathing, and a problem with her walking, and swallowing as well. But she was able to speak fine. There was no problem. So she had some, but not other things. And I guess it affects everyone differently. Okay, so yeah, but with Gyan Barre, if it is caught early, then it can improve. Yeah, so you get the relevant assessments done. They go to the correct person after they've seen their GP, get triaged to the neurologist, and they will be able to do tests to work out what's going on with them. So it's beyond us. Yeah, it's beyond what we do. But that's the whole point of this, is to show you that to pick up things that just don't seem right. And you, rather than keep on plowing on and going, well, I'm going to try and fix your elbow, actually there's a lot more going on. Would there be any blood tests, or would they pick it up quite soon at A&E? Any tests? What they would do at A&E, if with this lady in particular, because for me, I would have thought that she'd had a stroke. Yeah. So from the palsy on the face and the weakness in the arm, that would have been a red flag for me to get her to A&E, thinking that she'd had a stroke. So they will have done all of the relevant tests to analyze whether there'd been some kind of infarction. Okay, so whether it would have picked up Gyan Barre or not is unlikely if she'd gone to A&E, but she would have done eventually, because what they would do at A&E is test for all of the life-threatening stuff first, and then they would, if those are all negative, then they would go down the neurological assessment route. Okay. Yeah. So stroke can affect different sides. Yeah, definitely. Yeah. So and that we always think as well, going off the stroke subject, but you always think of a heart attack down the left side. You can have heart attack symptoms on the right side as well. Yeah. Yeah, it's probably perfect. Yeah. So highlights the importance of the red flag system. It's probably the most reliable screening system without needing to be specific. And that's exactly it, Fiona. You can't, unless you have access to blood tests, MRI scanners, CT scanners, and whatever else you need, you can't diagnose these things in a clinical setting. You can have an idea that something is wrong with different bits of the body, but you wouldn't be able to hang your hat on a diagnosis. It's really, really difficult to do. Okay, it's really difficult with the limited testing that we can do in a clinic room. Okay, really good. Some very good questions there. So I just wanted to go into this a little bit more because I gave you a bit of a challenge to look at upper motor neuron lesions and what they were. And I'm going to show you a little example in a second as well. So the nerves in the central nervous system that carry the impulses for movement are known as upper motor neurons. And if you have an upper motor neuron lesion, it means that there is a problem with the nerves in the central nervous system. So it's not the usual ones that we think about, which are the nerves that then come out of the spinal cord and supply your legs and arms and whatever, the peripheral nerves. It's to do with the central nervous system, so the brain and the spinal cord. Okay, so an upper motor neuron is something to do with either the brain or the spinal cord before it synapses and then goes into a peripheral nerve. All right. So upper motor neuron lesions are designated as any damage to the motor neurons that reside above the nuclei of cranial nerves. So those are the nerves that control the face, so the muscles and the sensation in the face, or the anterior horn cells of the spinal cord, which is the section before it gets to a peripheral nerve. Okay. So it's everything that is before the periphery. All right, that's an upper motor neuron lesion, so brain or spinal cord issue. And they can be any of these things. And this is why I would have referred this lady, okay, because they can be cerebrovascular accidents, which is a stroke. Yeah, so it could have been a stroke. It could be a traumatic brain injury. There wasn't really anything in the history to suggest that it was, but it could be. There could be a malignancy, so it could be some kind of tumor. It might be an infection, an inflammatory disorder, a neurodegenerative disorder. Okay, so it might have been, and with this lady, it probably was. So something that was, exactly, Natalie. Yeah, so it can blow your head off if you're kind of looking at it for the first time. It's like, oh my God, I don't even know where to start. So hopefully this will make a bit more sense of it. So a neurodegenerative disorder is probably what this lady had, because it was getting worse over time, over the months. So it's linking in more towards that. Okay, and metabolic disorders as well. All right, so upper motor neuron lesions can be any of those things. So when you're looking at the symptoms that lady had and all the possible things that it could have been, the list is huge. Yeah, it could be about 1,000 different things, but we just know it's not right. Yeah, we know that there's something not right with the kind of symptoms that she's got. So let's just have a look at it. Hopefully this will help. So when you have a problem with the brain or the spinal cord, it has a certain effect on the body. Yeah. So if you have a problem with an upper motor neuron, you will have spastic paralysis, which means that you'll have a contracture paralysis. So your limbs will be stuck in position. Okay. There'll be a hypertonicity, so an increased tone, and that's because of the spasticity. So when you feel the muscles or you watch them move, they look stiff. Yeah. So maybe because their gait was stiff and there was a problem with their gait. So that might be the reason why. They are hyperreflexic. So when you test reflexes, and I'll show you a video in a second, when you test the reflexes, it's not normal. Yeah, and I won't spoil it because you'll see a really good one in a sec. They get what's called disuse atrophy. So atrophy is where the muscles start to waste away, and they waste away, which sounds weird because they're working all the time, but they waste away because you can't use them because they're constantly contracted, they're constantly in spasm. So they get fatigued and they start to atrophy that way. So rather than an atrophy from not using the muscle, they're getting it from using it too much, and it's always on. Okay. And then there's another test which is a neurological test called a Babinski test. Now, This one is if you scrape something up the bottom of someone's foot, if they have a normal reflex response, then their toes should curl inwards. Okay, so that they'll come in to towards the sharp object. So as you scrape up the undersurface of someone's foot, their toes will start to curl downwards. Okay, but in a with an upper motor neuron problem, as you scrape along the foot, their big toe and the other toes will start to separate from each other, and the big toe will start to go up. Okay, and that's called a positive Babinski's. So as you scrape the undersurface of the foot, the toe will flare out, and they'll start to flare out like that. Okay, that's a sign that there is something wrong with the brain or the spinal cord. All right, so it's a very, very simple test you can do, but it's one that's done in hospitals, and they'll do that. Anybody with any kind of paralysis, they'll do a Babinski. Okay, so basically, with an upper motor neuron, everything is up. Yeah, so everything is more, and the toes go up. So everything is up with an upper motor neuron lesion. And let me just show you this. So when you test someone's reflexes, they look a bit like this.
Welcome to Ortho Eval Pal, where we help you build confidence in your orthopedic evaluation and management skills.
Right. Hello, my name is Paul, and this is Mr. Nightingale. Mr. Nightingale is 59 years old, comes to us today with a diagnosis of progressive weakness in this leg with some osteoarthritis in the right knee. Interestingly enough, when he's evaluated today, we find some other neurological signs and symptoms that kind of raise a red flag and indicate to us that we probably need to look into this a little bit deeper. Back in 2001, he underwent a cervical spine surgery for severe stenosis at C5, C6 and had a fusion. And recently has noticed this progressive weakness in his leg. So I'm not going to go through much more history than that, but I will show you some of the physical findings that we've had. All right. So I'm going to start off with his reflexes first. And we're going to go upper for now, and then we're going to work to the more significant areas. So C7, that's a 3+, quite hyperreflexive. C5, C6. So all about 3+, equal to this side. And then we're going to check his L4 on the left side. Quite hyperreflexive. S1. Okay, now we'll be careful on this side. Okay, so L4. Okay, and look, we have some clonus in the leg. We can stop it by pushing on the Golgi tendon organ just above the knee.
Okay, so just wanted to show you that. So what should happen when you do your reflexes? I'll see if I can draw it out on here. So if I draw a muscle, it's obviously what a muscle looks like. There we go, and a tendon there. So you hit the tendon, okay, and what that does is it then stretches the tendon. So you usually do the knee, like with that chap there, okay. So you hit the tendon, and then the tendon stretches, and what it will do is it will stretch the spindles in the muscle, okay, and they're like coiled springs around the muscle fibers, and they detect the stretch. So when that stretch is detected, a signal is then sent into the spinal cord. That's my best drawing with with a mouse, okay. And then to protect the muscle from over contracting, you'll get a signal coming back to the muscle to tell it to relax. Okay, so that's what should happen normally. So if you've ever had your reflexes done, thank you, Fiona. If you've ever had your reflexes done, then you'll get a little jerk reaction, and that's what should happen. So you get muscle spindle stretch, and then the signal will pass into the spinal cord, and then it will come back on itself So you'll get sensory information going into the spinal cord, and then you'll get a motor neuron coming out into the muscle, which will then discharge the muscle so it doesn't contract again. Okay, so it kind of knocks it off. The problem is, so this is what you see in all the books. Yeah, you'll see this diagram, but it doesn't tell the whole picture now. So what happens is, so this cloud-like structure here, that's your brain, clearly. And what will happen is, as that sensory information is coming into the spinal cord, at the same time, what it will do is it will send a message up to the brain and let the brain know what's going on as well. Okay. What the brain will do is it will send a message down again, and to modulate or to change the tension within the muscle so it relaxes. Okay. If you've got a problem with your brain or your spinal cord, it doesn't modulate the information. So you get what happened with that guy there, where you get a constant reflex. Yeah. And it's called a clonus. So if you get that clonus reflex, that is a sign, another sign of an upper motor neuron lesion. And it could be any of those things that we just talked about. So it could be any of those. Yeah, could be a stroke, could be a brain injury, could be a malignancy. It could be any of those that is causing that problem, and we wouldn't know. We would just know that they have a clonus reflex. Yeah, so that's one of the tests that we can do in clinic to make us go, that isn't right. You need to go and get checked out. Okay, so that's something to think about. Now, what we I'll do it on another day because it'll be too much. I'll talk about lower motor neurons on another day. Okay, so this was the other thing as well. Somebody examining the issue is between the brain and the spinal cord, not the spinal cord. Yes, exactly. So the problem there with an upper motor neuron lesion with the reflex is not to do with the peripheral nerves. It's to do with the central nervous system. So the brain and the spinal cord, somewhere in there is a problem because it's not able to modulate or control that part of the body like it should do. Okay, so that, yeah, really good question. So we also picked up a B12 deficiency caused degeneration of the, so a B12 deficiency causes degeneration of the dorsal column of the spine. So this is a section of the spinal cord that sends proprioceptive information and fine touch sensation back to the brain. So basically, if you have a B12 deficiency, you can't sense stuff very well, and you also get a bit stumbly because your proprioception goes. Okay, so a B12 deficiency can cause degeneration of the dorsal column, and that column is the is where the information going up to the brain isn't getting there so well. Okay, cool. Thanks, Natalie. It's our work, this one. Okay, and it will also degenerate the lateral white matter of the spinal cord. Okay, so this can lead to a degeneration, so a breakdown of the lateral corticospinal tract. And you don't need to worry about the names, but what that bit does, that bit is responsible for sending motor signals, so the bits that turn on the muscles, from the brain down the spinal cord. Okay, so that particular tract is a motor tract. So part of the spinal cord that sends motor impulses. Okay, and you will get upper motor neuron signs. So like we've just seen, if you have a B12 deficiency, yeah, and that could have been the case in this case history as well. Yeah, so that there was a couple of things going on there. So hopefully that makes a bit of sense. So something nice and easy. It could have been tennis elbow. So what do? This is one of the tests that you can do. I'll show you this one.
In this video, I'm going to show you a quick method to test for tennis elbow, also called lateral epicondylitis. Hi and welcome back to Physio Tutors. This method, that is unfortunately nameless, puts stress on the extensor digitorum that also originates from the lateral epicondyle. To perform the test, have your patient in a comfortable position, stabilize the humerus and palpate for the lateral epicondyle. Then ask your patient to pronate his forearm and then resist extension of the third digit of the hand distal to the proximal interphalangeal joint. This test is positive if your patient complains about sudden pain at the lateral epicondyle. Alright, this was one method.
That was a bit easier, that one. Okay, yeah, so that's Morsley's test for tennis elbow. That's one of the tests that you can do. So if you palpate the lateral epicondyle, and then well, if you do it yourself now, actually, if you hold on to the lateral epicondyle and then just wiggle your middle finger, just make sure there's no one around sticking your middle finger up at them, and you should be able to feel the tendon contracting right on that lateral epicondyle, and it's usually that muscle. So it's usually the extensor carpi radialis brevis that's the issue. But the extensor group will attach into that area, and that middle finger is a classic one for tennis elbow. So that's a nice easy test that we can do in clinic. Had a question there from Fiona about restless leg syndrome and B12 being linked to that. I don't know, to be honest. It's something that I'd have to have a look at. I think you would get altered sensation, so potentially. I'm not really sure. I think there's lots of reasons why you might get sort of restless leg syndrome. I think it's a multitude of things that it could be, but I'm guessing from the symptoms that you could get, it could be linked to that, but I'd have to look, to be honest. Okay, so worth checking that one out. Cool, that's it. Yeah, so quite a tough one this week. All upper motor neuron lesions and all that kind of stuff. So hopefully that's given you a little bit of more understanding about them and what they are, and what the signs and symptoms are for them. We're going to do a new OSCE on Monday at 6 o'clock. So I'll come up with a new one for next week, and have a good weekend, guys. Thanks very much. Cheers.